Yes.
Yes, thank you.
Good morning, everyone. I hope you had a nice day yesterday. I see at least people are satisfied, even those who were not here physically. So yesterday was full of nice information. Today we also have a program before us. May I acknowledge the presence of the DBC ACT, Professor Kamhagwa. And you are all welcome to this second day of the 9th Muhasi Scientific Conference. We start with the plenary session, and thereafter we will have poster viewing, and then we will go to the panel session before lunch break. After lunch break, we will have satellite session, and then we'll have a closing ceremony. So welcome everybody to this plenary session. May I now invite Dr. Roderick Senge, who is the chair of the coming session, to introduce us and welcome our keynote speaker this morning. Dr. Senge.
Good morning. Thank you, Professor Kawabuka. So I'm going to chair the keynote speech or address, and this will be given by Professor Anamia, and she's giving it from Care Institute. And this is going to be virtual. And the topic is sorry about that. And the topic is the direct and indirect impact of COVID-19 and the COVID-19 vaccine. Professor Anamia is a known professor of global public health at the KI Institute in Sweden, and she has a vast experience in leadership, over 20 years of teaching, research collaboration. She has mentored several PhD students, and more important to this particular session this morning, she is actually involved in COVID-19 response strategies. For example, she is a member of the WHO COVID-19 of COVAX facility allocation of vaccines. And with that brief introduction note, I'd like to invite Professor Anamia. Welcome, Prof.
Thank you. Thank you very much for inviting me to speak at this conference. I'm very happy to take any questions at the end of the session, so don't hesitate to ask questions or interrupt me if anything is strange along the way. I have been part of the SIDA financed MUHAS and KI collaboration for many years, and I'm very happy to talk to you today about the direct and indirect impacts of the COVID-19 pandemic and COVID vaccines. Let's see. So, as you very well know, the world is facing this pandemic, but it is very unequal how it strikes, both in terms of the disease, the deaths, but also access to vaccines. And we have very much focused on the direct effects of COVID, which I will start with, but the indirect effects of the lockdowns have been very much felt in many African settings in particular, perhaps a little bit less so in Tanzania, which hasn't gone into the extreme lockdowns we've seen elsewhere, for example, in Uganda. But so I would like to focus on sort of the indirect effects of the lockdowns and of the pandemic in Africa more as a whole. This is a citation from Tedros, the WHO General Director, saying that the COVID pandemic is perpetrated by scandalous inequity in vaccine distribution. So I will end and talk a little bit more about vaccines in the end. So if we just look at the situation right now, this is a picture from last night where we see the cumulative number of COVID cases per million people. And you see the darkest number are the ones where we have the highest number of cases of COVID per million people, obviously influenced by access to testing. So it might be underestimated in many places, but still we see that this looks very different than it did a few months ago, when all African countries had sort of very low number of cases registered. We now see that South Africa in particular, but Southern Africa has many more cases per million, obviously related to testing, but also to differences in the epidemic. Most of my slides here are available at Our World, or the pictures are available at Our World in Data, which is one of my favorite sites that I can really, really recommend. It has tons of data on all sorts of variables, not only COVID, but lots of other variables too. So if we look at the daily number of confirmed cases per million in a different way, where I've selected Europe in green, and Africa is in brown here at the lower end. Can you see my cursor moving on the screen? I hope so. So Europe is the green in the end, which peaked in terms of cases before Christmas and then has gone down and had another peak in the spring, and is now went down quite a bit, but then now is a little bit on the rise again, but not as much as before. The same thing with the United States. It had an enormous peak around New Year's, but now has come down quite a bit, but increasing a little bit again. While Africa here, as you can see, very low number of cases in comparison to most other countries, possibly due to testing frequency. This is just Sweden, which had two big peaks last year and then in the spring, and now very low, so lower than the rest of Europe in terms of number of cases, probably due to the high prevalence of coverage of vaccination. So here's Tanzania, which there is very few cases reported from Tanzania as compared to the rest of Africa. So driving the incidence in Africa is really South Africa. See a very sharp increase in South Africa. If we look at deaths, that is also changing over time. Obviously, this is for over the last week, the rolling average, where you also see that Southern Africa is quite heavily affected as well as South America and Russia, but also parts of Asia, while deaths have gone down very much in Europe, North America, and are still very, very few reported from the largest part of the African continent and Australia. One of the reasons to the rapid spread the sort of renewed spread in many countries now, including in the third wave on the African continent, is a variant of the virus called the Delta variant, which seems to be more transmittable. So, but it has a very different effect in different countries, depending on how many that are vaccinated. So we see that the vaccines protect very well against not the transmission so much until you reach a very high coverage, but against death and disease, which is really what we want to get at. So there is no data from Tanzania on the existence of the Delta variant, but we see that it has really taken over in most countries in the world. This is from Kenya, United States, and South Africa, where the great majority of cases are the Delta variant. It doesn't seem to be more fatal. It's just that it infects more people, and then more people get sick. And then if there is no treatment available, or which is mainly oxygen treatment, of course, in general care, no other drugs are really effective. It's deaths also occur more frequently, obviously. So even though, as you saw in the previous pictures, the number of cases have increased in many places, and also that the Delta variant is as common, for example, in the United States as in South Africa, we see that deaths are still much higher in South Africa due to the lower access to oxygen, obviously, in hospital care, but mainly due to the lower coverage of vaccines. So up until now, we have really seen, up until very sort of recently, the last few months, we have seen very few deaths actually reported from Africa due to COVID-19. Obviously, there is an underreporting, but in comparison, deaths have been fewer. And much of this is probably explained that by the distribution of age in the population. This is a picture showing the proportion of people above 80 years of age in the world. And as you see, the darkest color here is in Europe, where we have very old populations. And while the lightest are in Africa, which is, of course, no surprise, where 40% of the population in many countries is below 25 years of age. The risk of getting sick and dying from COVID should be very, very low in young people. And in fact, the absolute number of people on the whole sub-Saharan African continent is probably about the same as in one country, Italy, only this little small country here. So that has been the explanation that most people have seen as for why deaths in Africa have been so low for COVID-19, and age is still by far the strongest risk factor. Obviously, apart from age, also diabetes, obesity, cardiovascular disease, sort of having a ground condition that is also increases the risk of COVID. On the other hand, we haven't really seen any strong effect from, for example, living with HIV, tuberculosis, malnourishment, or other conditions. So it's really old age that is the strongest factor so far, but then underlying conditions. Well, when COVID hits countries where we don't have a lot of very old people, then obviously those who become affected in the absence of healthcare are slightly younger people. So we see that in the African continent, deaths occur more among the sort of 50 plus, 40 plus. That's the dominating group when they get affected, partly because of the very few numbers above 8 years of age. So moving over to the extreme indirect effects of this pandemic, which I am very concerned about, and which so far little has been done really to mitigate these. This is a graph from the World Bank showing poverty rates in the world. And we see that the poverty has declined quite rapidly over the last 5 years in the number of people in millions living in absolute poverty below $2 a day. But as of last year, we see a very sharp increase in the number of people living in extreme poverty due to the pandemic's effects, mainly the lockdowns. It's actually, it's not the effect of COVID itself, it's the effect of how countries have reacted to COVID. That is what's causing poverty, mainly, since the great majority who have died in many parts of the world are very old people and less generating sort of income. So this is really mainly due to unemployment, loss of food security, and lockdowns inhibiting exports, imports, and production in the world. Estimating that poverty will rise with about 150 million people this year. We also know that food insecurity has been affected very much, or due to lockdowns and lack of trade, and also not being able to harvest or go to the market. We knew that already before the pandemic. Africa, the African continent, obviously was the one hardest affected by food insecurity to start with. And the World Food Programme estimates that 135 million more people will have been pushed into extreme hunger due to the lockdowns in the world in response to the pandemic. The effect of school closures is very, very serious. And many countries are starting to really see this and regret that they ever closed down schools. This is a few weeks ago, the total duration of school closures in the world. And as we can see, the picture is a little bit different, because even in African countries where the number of cases and the number of deaths have been relatively low compared to most other countries in the world, schools have been closed longer, with extreme impacts on, in particularly, girls' livelihoods and opportunities in life. So despite the fact that children have an extremely low risk of dying from COVID themselves, becoming sick from COVID, and even don't serve as a major source of transmission, countries have often chosen to close schools because it's sort of what they can do. It's sort of the tool they see they have. But in my view, and it's also the view of UNESCO and UNICEF, the school closures have actually hit the children much, much harder in an unfair way that societies probably will suffer from for a very long time. So children have paid the price for this pandemic without actually being at risk of disease. In fact, already 160 million, 8 million children are estimated to have been out of school for over a year. And some schools have offered sort of online teaching, which is of course difficult if you lack access to electricity and internet, which is the case for many children in low-income countries. And even in rich countries that have access to internet, distance learning has shown to be very poor, actually, in terms of learning. Save the Children made a study on about interviewing over 17,000 children and 17,000 parents and 8,000 children, and they found that most said they hadn't learned anything or nothing, little or nothing, 80% of them. Many children have been pushed into child labor. This is a photo of a 10-year-old girl in Nairobi that when she left school had to start working in a quarry. We know that already from the beginning, literacy is a problem in many school-aged children. And it's been feared that 24 million children will never return to school after the school closures because they have been married off in child marriages or forced to work to support the family. We also know that schools make up an important source of nutrition, and it's estimated that almost 400 million children have missed 40% of their daily nutrition due to not getting food in school. We also know that violence has increased very much, both violence against women, but also against children. And the people report in this study from Save the Children that they have violence has doubled in homes where after schools were closed. The long-term effects are even more daring. Trillions of dollars are thought to have been lost in life incomes due to missing this 1 year of school. So the school closures have had an extremely negative impacts on children's lives and on societies as a whole. And especially for girls, where more than 10 million girls are estimated to have been subject to child marriage due to the school closures, where schools often serve as a safe space for abuse, but obviously also give opportunities for life. Countries that practice female genital mutilation also see that this has increased when schools have been closed, and up to 2 million girls have been subjected to this traumatic experience because of school closures and the pandemic. In the WHO's surveys, they made a survey last year, and then once again in the early first quarter of this year. They also looked at the impact of the pandemic, or sort of the lockdowns and poverty, on other diseases apart from, and other healthcare services apart from COVID. And they found that in 105 countries where they reported key informants, 70% reported the reduction in access to child immunization and contraceptives. This is routine child immunization, than measles, for example. So more than 100 million children are estimated to have missed their measles vaccination, laying the ground for actually other and new epidemics in, for example, measles, due to missed immunizations. So this is, of course, very serious and something that countries need to try to catch up with as soon as possible. Maternity care is another very serious area where access to care has been lower, especially when some hospitals have been closed, clinics have been closed, people haven't been able to get to the clinic to give birth and get assisted birth, but also not being able to go for follow-up at antenatal care. So it's been estimated that at least 100,000 more women have died due to the lockdowns and lower access to healthcare. And millions of unwanted teen pregnancies and unsafe abortions are also seen. Even in the first 3 months of the lockdowns, it was estimated that 15 million teens were unwantedly pregnant due to school closures primarily, and being isolated and locked up at home. We also, so part of this abuse is the sort of the shadow pandemic, it's called, of gender-based violence, which is estimated to have doubled in many countries across the world during the lockdowns. And in particular, this has been reported from South Africa, but all countries, including Sweden and high-income countries, we see that when women are isolated at home, and there is stress, financial stress, and people can't leave the house, we see that violence has increased, and also murder of women across all continents. The impact of child deaths is so far to be estimated, but it is likely that already as many young people have died from the lockdowns as older people have died from COVID. And we think that the indirect deaths caused by sort of poor access to care, poor access to prevention, poverty, food insecurity, lack of immunization for basic childhood diseases, etc., may lead to a higher number of people dying from the indirect impact of the pandemic than the direct impact over time. In particular, we fear a rise in, for example, cancer illnesses in high-income countries, where very many have been underdiagnosed or not diagnosed. On the African continent, unfortunately, I think we can expect to see an increase. We have already seen increase of the lockdowns, poverty, all of this lack of immunization in children, and there are estimates by the WHO that we'll also see increases in malaria deaths, TB deaths, and AIDS deaths. These are all modeled data, and I haven't seen actual reports on primary data. So much of what I'm talking about is modeled data, and we're still waiting to get primary data from many of these sections or areas. So I just want to raise that as a precaution. But the models are that if services for TB drop for 50% by 50% for 3 months, that could lead to 400,000 excess deaths of tuberculosis in the world, according to the WHO. if services for HIV would drop by 20% over 3 to 6 months, it could result in up to 100,000 excess AIDS deaths across the globe, and primarily then affecting countries with higher HIV burden, such as Tanzania and other countries, obviously. So I wanted to say something about the vaccines as well. It seems like lockdowns have extremely negative effects and can only temporarily actually stop the spread of the virus. We see that this country is an isolated island, really. And estimated this is by far the most cost-effective intervention that countries can make, since the global economy is also losing an enormous amount of money every day and month due to keeping the pandemic going and the effects on trade, work, production, and of course health. So this is a snapshot of the COVID-19 vaccine situation, where more than a quarter of the world population has so far received at least one dose, and 13% are fully vaccinated out of the almost 3.9 billion doses that have been administered globally. But these are extremely unfairly distributed and allocated in the world. Only a little bit more than 1% in low-income countries have received at least one dose. And this is due to high-income countries, including my own, and also Europe, really making their own bilateral deals with pharmaceutical companies that sell to those who pay the highest price, obviously, and also export embargoes on essential vaccine components, for example, by the United States. We've also something that had a very big effect on access to vaccines through the global COVAX platform that I soon will introduce and talk more about, is the fact that India saw this surge in cases and had to prioritize their own population. And India is the largest vaccine producer in the world overall. And this severely impacted the plans of access to global vaccine, in particular for low-income countries. So there are many explanations, including also patents and the very skewed distribution we have of vaccine production in the world, where absurdly Africa needs to import 99% of all the vaccine it uses. And these vaccines are very rarely produced in Africa, but elsewhere that is true for all vaccines, not obviously only COVID vaccines. So something that people are starting to discuss very much is how to prepare better for future pandemics, including scaling up vaccine production on the African continent to become more self-sufficient and less dependent on countries that are obviously mainly prioritizing themselves. We also see that these vaccines are extremely effective against serious illness and death after 2 doses. And we see very rapid declines in deaths and disease. In Sweden, there's just a sort of a handful of people now in intensive care for COVID due to the high vaccine coverage, about 60%. But we saw these declines coming already at 10 to 20% of the population being vaccinated, because that covered the elderly and the risk groups. And then we saw this very rapid decline in deaths and disease, but also in transmission. I wanted to start a little bit by saying something about the main types of vaccines. So there are different types of four main types of vaccines. I won't go into detail of this at all, but they're the whole virus vaccines, which we are sort of, it's a type of vaccine that have been used before, for example, to vaccinate against hepatitis B, polio, rabies. They're all inactivated whole virus vaccines, and 2 doses are required. The main examples of this for COVID vaccines are the Chinese vaccines, Sinopharm and Sinovac. And they appear effective, but there is against both disease, very effective against disease and death. But how much they protect against transmission is, especially for the Delta variant, is still not out. It's not known. Booster shots, I should say, may be required from all vaccines. We have the new type of vaccine called the mRNA vaccines. The Pfizer and the Moderna vaccines, where also 2 shots are required. And it's very important that you need, the reason you need 2 shots is that protection more than doubles, and is much more long lasting and long term after 2 shots. 1 shot, you have half of the effect, and it wanes quickly. So for all vaccines, except for the Janssen vaccine so far, 2 shots are really necessary. But we see impact already after 1 shot, but for the long term, 2 shots are necessary. So this is a new type of vaccine where mRNA molecules are sort of used to transport the vaccine into the cells, and then instruct our cells to produce first antigens, and then the body activates its immune system and triggers an antibody response. All the vaccines are thought to activate both the B cell and T cell immune response, and the T cell is probably what makes it the most long term. These are assumed to have, so far, obviously, one should say that long-term studies are lacking for all vaccines since they haven't been around for more than half a year, but so far seem safe. And most people get a strong immune reaction immediately for most of the vaccines, like a sore arm, fever, swollen lymph glands, etc. So it's important that people are informed of that. This is not, doesn't mean that you have got the disease at all. It's just your immune defense, because none of the vaccines can cause disease. They're all just small molecules or inactivated virus. The problem with the mRNA vaccines in the beginning was really the freeze chain, that it required ultra cold and ultra cold chain. This has now changed. So they can actually be stored in sort of refrigerated temperature for up to a month, sort of in the normal cold chain. But one other problem is that they have been more expensive. We have a non-replicating viral vaccine, the AstraZeneca vaccine, that I have been immunized with, for example, in Sweden. All health workers in Sweden were immunized by the AstraZeneca vaccine in the spring, pretty much. So this is also fairly new, but the technique was used in to vaccinate against Ebola. And this is also a vector transporting sort of the antigen copy into the cell, triggering the immune response. There were lots of rumors about the sort of side effects for this vaccine in Europe after seeing very rare 1 in 100,000 blood clots, in particularly in younger women in some countries, but not so really in the elderly risk groups. It also has a very strong protective effect against both disease and death. Lastly, this is not yet on the market, the Novavax. It's in phase 3 trials, but it's the protein subunit vaccine, which is a well-established technology, but more slow and actually expensive to produce in large numbers. I have a few minutes more that I will talk, and then I'm really happy to take questions. But coming back to the extreme unfair distribution of vaccines in the world, we see that low-income countries, this blue line at the bottom, has only received about a little bit more than 10 million doses so far, while high-income countries have hoarded more population, but still the vaccine coverage in these countries is actually lower. We see here that vaccine access in Africa very, very, very small and not really increasing as of yet. While in Asia, it has increased a lot. Europe sort of same across the board. This is sort of the relative proportion of access to vaccines. North America, Oceania, but it's really high-income countries having received, high and upper middle-income countries have received more than 90% of the vaccines so far. And you see here the proportion of people who have been vaccinated across the world. The darker the color, the higher the proportion. And in many European countries, North America, we see vaccine coverage rates over 60% of the population. While, as I mentioned, on the African continent, on average, less than 5% of the population has been immunized so far. And in low-income countries overall, only about just over 1%. So this is illustrating the number of doses, as I said, but in a different way. So because of the high population, we see a lot of vaccines has been administered in China and India, but of course also in high-income countries, but they have much smaller populations. We see that this has very excess deaths. We had a lot of excess deaths in Europe last year in the spring, up to 100% higher excess deaths in some countries, like the UK spiking, for example. But now, after the vaccines have been administered, Sweden has negative excess deaths, so much fewer than could be expected due to the vaccines, and also because many elderly who were very sick died early on in the pandemic, when we didn't have access to vaccines and sort of healthcare resources were overwhelmed. We see the same impact in all countries, really, that have vaccinated the populations, that death rates really drop dramatically, very quickly, even when only about 10% of the population has been immunized. If you vaccinate risk groups first, then deaths drop. This is the predictions that was made by the Economist late last year, that most of the African continent and other low middle-income countries in the world, and primarily in Asia, and would receive vaccines late as of next year, while rich countries have sort of bypassed the queue and bought up most of the vaccines and have big access. And we see this also on this webpage from Duke University, which I can also recommend. Actually, it has very interesting data on purchased vaccine, manufactured vaccine, etc. It's the launch and scale speedometer offered by Duke University for free. This is what it looked like yesterday when I downloaded it. That population coverage, the greener, the higher. And you see the absurdity with Canada having 8 to 9 times the number of vaccines that they actually 8 to 9 times doses per person available, 400 times more than they actually need in terms of contracts. This is also showing that low-income countries have so far procured very few doses. This is the COVAX facility that I now will talk more about. Lower middle income, upper middle income, and high income countries have by far the highest number of procured doses. So what is then COVAX? COVAX is a new platform that was created last year, about a year ago, with co-led by the WHO and Gavi and CEPI, which is the pandemic Center for Pandemic Control in the world. And the idea from the beginning was that all countries would pool their money into COVAX, and that COVAX would negotiate with pharmaceutical companies to lower the price of the vaccines and then distribute them fairly across the world, so that all countries would receive up to 20% coverage first, before we start and vaccinate its risk groups and health workers, before any other people were immunized. This mechanism allowed countries to come into in 3 different ways: committed purchase, optional purchase, and advanced market commitments. And most low and middle income countries in the world, 92 countries, entered into this group, where they would get subsidized vaccines paid for by the other countries, and through ODA or through philanthropes or the private sector, but also paying a share themselves. So this was the idea, to immunize at least 20%. It still is the idea, actually. But it has been slowed down very much due to the lack of vaccines, because high-income countries haven't really, they have bypassed this mechanism and made bilateral deals, sort of pushing ahead of the queue, ahead of COVAX, and also paying much more money to get the vaccines first. So there is now added a new dose sharing mechanism to where countries that have over contracted, sort of like Canada, the EU, the US, can now also share their doses and sort of transfer their contracts to COVAX, who gets the doses instead and can distribute them in the AMC, low middle income countries that can't make their own deals with pharmaceutical companies. So this is the coverage of COVAX, sort of. So most countries are members, but they are in different categories, where the orange countries are sort of would get subsidized vaccines through COVAX, while some countries would mainly sort of finance, but also get, and some actually also get their doses. So countries have, if you enter the deal, you were supposed to get sort of cost of vaccines at a low price, also in high and middle income countries. So some countries have received, higher middle income countries has also received small shares from COVAX, because they have entered into this deal to contribute financing to the mechanism. So how does it work? Well, countries first, COVAX estimates the supply forecast based on what countries want. They send in national deployment plans and preferences for what vaccines they want to have when available, and how much they can pay, and what target groups they want to target. And then we sort of match the supply to the preferences depending on how much vaccine that has come into COVAX. I am part of this group, the IAVG group, which is an independent group, unpaid, of 12 experts in the world that are asked to make the formal decision of the allocation of available vaccines. And during several months, there were much less vaccines to access, but now actually supplies have increased quite a bit for Q3 this year and Q4, the end of the year. So we have meetings almost every week now to allocate more vaccines. But then there is a delay between actually making the decision and delivering the vaccines, because the vaccines aren't always actually available. They also need to be produced and distributed, oftentimes through UNICEF as a partner in most countries. This is, for example, how a map can look when we sort of, it's artificial intelligence, then how many doses each country will get. All of the countries are here below, depending on what they have asked for, what they have received before, cold chain availability, preferences, and they can also say no to vaccines that they don't want. And then we try the most important, it's a very transparent actually process. So artificial intelligence is used, but also now looking more into the epidemic situation. So countries that have big problems should be prioritized first according to a sort of objective model that is yet to be decided, but probably last month's trends, but also overall coverage. So countries that already have a high coverage may have then be lower prioritized than countries that have very little. And the aim is to reach up to at least 20% coverage of people in every country, and that would be enough to cover risk groups and health workers in all countries across the world. So countries are sort of assisted to write these deployment plans if they need to make sure everything is in place before vaccines are allocated and distributed. This is a picture from Ghana, I think. And this is how it's been delivered in Kenya. So in fact, we see that sometimes even the day after we have made a decision to allocate vaccines, they are actually distributed and transported to the countries in question. So the main bottlenecks is really the lack of vaccines, that vaccines are not produced at enough numbers, and those who are produced have mainly been hoarded so far by rich countries. There are also export embargoes on essential drugs or essential components and vaccines, and reduced supplies to COVAX, both that pharmaceutical companies sort of favor contracts with countries that pay more, but also because of reduced supplies, for example, from India, from the Serum Institute of India. But so far, 138 million COVID vaccines have been administered to 136 countries. And the plan is actually to reach 500 million doses supplied, or up to 700 million doses supplied by the end of this year through COVAX. And it seems like actually that can be fulfilled with the current contracts that are in place. So even though the delays have been very unfortunate and many, and out of the control of COVAX, we think that we will reach the goals that were set for 2021 as planned. So for the future, rounding off, most of these sustainable development goals have been affected by the pandemic, both the indirect and indirect effects of the pandemic. And I think it's incredibly important to invest in particular in research and life sciences to make sure that Africa becomes more less dependent on other countries in terms of vaccine access in the future. Thank you very much. So I'm happy to take any questions that you may have.
Thank you, Prof, for your presentation. Now the presentation is open for questions. You put up your hand, and then I will take the first round of about 3 questions or 4. And the question. Yes, Professor.
Thank you, Prof, for a very good presentation, and you have tried to highlight where we came from and where we are with regard to the impact of COVID-19 pandemic throughout the world. And you have highlighted key areas showing the different sectors that have been affected, but also you have indicated the impact that the vaccine can bring. And we have indicated clearly that supply of vaccine in developing countries like Africa, including Tanzania, it has been very, very slow, and we have indicated the reasons for that. So since we do not expect to get the adequate number of doses in the near future, that means we have to continue practicing preventive measures that are recommended by WHO. And we want to relate the experience you had in Sweden when the pandemic started in the very late 2019, that different measures that different countries use. Maybe you can tell us a little bit what Sweden did, what did work best, that probably also we can continue doing it in Tanzania when we are waiting for increased number of vaccine doses. Secondly, is this number of waves that people coming. Here in Tanzania, I think the first wave started late 2019. Then we had the wave, then I think in the beginning of 2020. Now this is July 2021, we have the third wave. are there models that you could predict these waves? Because these waves do affect the health systems, and especially when resources are limited. There are predictions that have been made that could inform the government, the Ministry of Health, so that we prepare ourselves because of the limited resources. And thirdly, as we continue vaccination, could you, or from the literature, predict that, for example, next year, let's say we reach 20% of the nation, of the people who are vaccinated across the countries? Do we see that this is possible? And if it is, do we see that the life may change, that because we have seen in some countries now, they have relaxed the restrictions, and economies have been open. We have anticipation what may happen if, for example, we have reached 20%. And is it known in the countries that, for example, if you reach, for example, I know I hear in some, for example, in America, they have reached 60%, in some countries have reached 40%. What is the percentage needed to cut the community transmission of the COVID-19? Otherwise, thank you very much for the good presentation.
Thank you very much for these questions. So in the first one, what did Sweden do? Well, Sweden didn't go into a hard lockdown because it's illegal in Sweden. It's sort of seen as undemocratic, and it's against the law to actually do that. So it wasn't possible, and also considered from the Public Health Agency as not a good way looking at all of public health. But Sweden implemented strong recommendations, and the Swedish people are sort of more used to follow what the government says. So in fact, more than 90% of people strictly follow the recommendations, even without being forced to, or having to fear any interventions from the police or harsh lockdowns. So in fact, distancing, I think, was the most important recommendation, 2 meters distance whenever possible. Initially, face masks were not recommended because the Public Health Agency of Sweden thought there was lack of strong evidence to support that, and were afraid that if people wore face masks, they would not respect distance. But later on, face masks were recommended anyway in subways and sort of indoors where it's hard to keep a distance and where ventilation may be poor. But we saw that, and they recommended that people would work from home as much as possible, which is possible, of course, if you have sort of digital types of jobs, but also to not use public transport at rush hours. And but importantly, schools continued, except for universities that had distance teaching, and the upper sort of secondary schools. But up to 16 years of age, all schools, 16 years of age, schools kept open. And it seems like the distancing worked very much. Hand hygiene, of course, very important. Cutting down the number of people who could visit a shop at the same time, recommending that people. So we saw that streets were pretty much empty. Shops were very few people were shopping, for example, and public transport use came down very much. So it seems like these recommendations actually worked. But then healthcare was still overwhelmed for a long time, and the strategy got criticized by other countries that had harsh lockdowns, and also who thought that face mask was the solution more than Sweden did. So the countries have applied different strategies across Europe, but even though Sweden didn't have lockdown, people did follow the distancing, which I think is the most important measure. Also prohibited conferences. Churches couldn't accept many. Very few could go to sort of churches, and there were no sports events or concerts, theaters. All of that was closed for almost a year. For Tanzania, third ways to predict. Yes, there are models to predict. I haven't seen one for Tanzania in particular, but the Swedish Public Health Agency has made all of these models, which actually have fitted very well to the actual pandemic, taking into account also the higher transmissibility of Delta and different measures. If people would follow the recommendations less or more than sort of today, there are models to predict. But for us, the warmer weather in the summer, when people are also more outside, which is now, plus the high vaccination rates, have really cut the transmission dramatically. It did also last summer, actually, even though we didn't have any vaccine then. The warmer weather and the fact that people spent more time outdoors really reduced transmission dramatically. So it is dependent on the weather as well. So warm, dry weather appears beneficial to cut transmission if people also follow distancing. So there are models that can be used. For vaccination, yes, I think it's possible to reach 20% vaccination by the end of the year, for example, in Tanzania. But I think one needs to work very actively on public opinion and hesitancy to vaccines. There are many rumors out there in social media, not the least, that vaccines are dangerous, etc., and sort of claiming side effects that we actually haven't seen. So I think that is a big challenge, and also make sure that the vaccination of COVID doesn't outcrowd other basic healthcare, which which also saves lives and really is very necessary. For example, child immunization. Thank you.
Thank you. Thank you. Maybe we have take some more questions. Yes, Dr.
Thank you very much, Professor Namia, for a wonderful presentation. I have two questions. One is specific for Sweden, and another one for the global community. One, as you say, in Sweden, schools were closed except for the children below 16 years of age, but the universities and other higher institutions, the classes were so. And of course, the experience from many other countries, as we hear that sort of transmissions may actually happens from the between the young people, the children, although they may not be sick, but they can transmit to the older people at home who are sort of in the lockdowns or something like that. Was this the experience in Sweden as your experience? That is one. Another question is directly to the global vaccines availability, usage, and yeah. So if you in your slide, the slide about the countries with the high and the countries with low vaccine coverage, surprisingly, Russia was one of it, and we know that the WHO approved vaccines. What could probably be a problem around this? Thank you very much.
Thank you. Well, for the school closures, it was sort of estimated or seen that children didn't serve as an important source of transmission, because also you can transmit the virus even before you get sick. But the sicker you are, if you cough, sneeze, etc., more viruses spread. And since children rarely get sick, there is much less of that transmission. So distance was kept in schools. Children didn't have as much as possible, but it's not always possible, obviously. But we found in Sweden that the benefits of keeping schools open greatly overweight the potential negative effects of some increased transmission. Since we saw that young adults are those that transmit the most. We see that the most transmission throughout the pandemic has been highest among sort of 20 to 30-year-olds, because they socialize more and are more active in society. To small children actually have not been seen as the major source of transmission in Sweden, despite keeping schools open. So the benefits outweigh, I think. Regarding global vaccine access, that we see that Russia has a low coverage. Yes, WHO actually has not yet recommended use of Sputnik, the Russian vaccine, for example, for general use. We still see it's used, and it's used across Africa and in some European countries, and for example in Cuba. So and the reason is that there is not, they say it's not, they don't have enough data really to say that this can be widely used. But it seems like from the studies we have that it is very effective. And it is probably as effective as all other vaccines. I see no reason to doubt that, but it's just that the data is lacking. And the reason really that Russia has a low coverage is that the Russian population is very skeptic to anything, I think, recommended by the government, and they doubt, I think, there's fear of side effects, and they doubt the vaccine efficacy. But the technique that is used for the Russian vaccine is very similar to the technique used for other vaccines. So I actually, there is no reason to think that it's worse or more dangerous in any way. It's just that it hasn't yet reached full approval. While the Chinese vaccines are in the, but it's under consideration. Thank you.
Thank you. Can we take 2 questions if anyone online asking questions? I've seen your hand for some minutes. Let's give anyone asking? Anyone asking question online? So, can you read the question?
So there's a question that says, yesterday in the media, there was that a new variant, the Lambda, may be resistant to these vaccines. Has this been considered in the modeling, and what are your thoughts on this?
No, it hasn't. And yes, it seems like for the new variants, I mean, it's the virus, the nature of the virus to mutate so that it can reach more people, but it's also the nature of the virus in a way to not kill its host immediately, because that would reduce, its survival. So what we think is that yes, a virus may become more transmittable, but it's unlikely that they will become more fatal. It's just that if more people get sick and there's no healthcare, obviously more will die just by sheer, mathematics. But no, Lambda hasn't been there. But what we've seen so far, at least, I haven't seen any studies on Lambda, but on the Delta, that vaccines protect extremely well against serious disease and death, although a little bit less against transmission, it seems. But what we fear is actually excess death and premature and serious illness that overcrowds our healthcare units. And it seems like vaccines are so far extremely effective to protect against all the variants available today for these 2 most serious outcomes.
Thank you. So in the interest of time, maybe we take 2 more questions. For some means you have your hand up.
Thank you very much, Anna, for nice and very elaborative presentation. I have a very interesting question that most of these vaccines require 2 repeated doses. Are there cases whereby one received, say, AstraZeneca vaccine for the first dose, and because of logistics and travel, perhaps one ended up to receiving the Pfizer vaccine? And if yes, are there advantages of getting different vaccines, considering that these 4 vaccines have nearly different molecular targets?
Yeah, I think if I heard your question, it was if one can mix vaccines. Is that correct? Yes, we can. Actually, I myself received 1 AstraZeneca and 1 Pfizer dose. And it seems like studies so far, even although vaccines are not sort of approved and licensed to be mixed. Studies so far show that it may even be more effective to mix one vector dose and one mRNA dose, for example. It seems like mixing is not a problem at all so far. It doesn't seem dangerous, and it may be even more effective for immunity, especially for long-term immunity. But so far, SAGE, or the sort of group that really goes through the safety of vaccines within WHO and COVAX, has not recommended the mixing of vaccines. But as more data come in on the impact of this, because in many countries, health workers have received a mix, I think recommendations may change. I myself is an evidence living person with two different types anyway.
Okay, thank you, Professor, for your nice presentation. I think we'll have to stop here. And let's thank you for the nice presentation, but also for the participants. Can you have a round of applause? A round of applause for our rapporteur, Professor Bion. That's one for the organizing team for selecting someone from ICT to lead the session.
Thank you so much, Dr. Kisenge. Thank you so much, Professor Anna. May we please bring together our hands for Professor Anna. Informative presentation. I hope next time you will be there again to enlighten us more as we will be moving towards controlling COVID-19 spread. Thank you. This brings us to the end of the plenary session. And now you will have time to go around to view the posters. Thereafter, we'll continue with the panel session. But I see there's an announcement.
So if you can check on your schedule, there is sort of there was in the main documents for lecture hall 4, and then it repeats lecture hall 4. So one will be lecture hall 4, and the second will be lecture hall 5. So this is for information. Yes. So epidemiology and demography will be in lecture hall 5. Is that okay? And while you're waiting for poster viewing, for those who do not have breakfast, can you quickly grab something to eat? The breakfast was a bit delayed. Thank you so much.
Sema kuifufua ile laptop ndio hii.
Sasa hii
1060.
70. Wewe umeshafunga? Iko bado. Naomba tuende. Tuende yule jamaa. Tuende. Kwa tulimpa host. Host ulisharudi kwako. Ulisharudi kwako. Sawa. Naomba tu end stream. Send meeting kwanza.